Good morning, good afternoon, everyone. It's just clicked over to 12. Thank you for joining us. Hopefully we get a couple more people in. Today we have the lovely Noni and Kelly joining us from the WA Cervical Cancer Prevention Program, and they are going to give us an update on all things that are happening in this space. So I'm just going to share my screen here. And there we go. Lovely. So we'll skip on through. Where are we here? All right. So before we begin, I would just like to acknowledge the traditional owners and custodians of the lands on which we meet today and pay my respects to the Whadjuk people of the Noongar Nation. I would also like to extend those respects to elders past and present, and again extending that respect to Aboriginal people in the room and online today. So, as always, we are recording this session. We will send it out. We have... Oh, it's happened again. That's okay. We will allow you to have questions at the end, and I will hand it on over to Noni.
Thank you for having us, everyone. I'm Noni. I am a registered midwife and I work with the WA CCPP, the WA Cervical Cancer Prevention Program, for the last 2 years. And I've got my lovely colleague here today, Kelly, who has replaced Kay Wally. For anyone who knew Kay, she was with our program for 11 years and has now passed that on to Kelly.
Thank you. He doesn't know how to talk.
And so we've got about a 30-minute presentation for you today. And yeah, we would love if you wrote down your questions and asked them at the end. We'd love to answer them for you.
Yeah, so when we do our presentations, we just like to remind everyone that we will be speaking about women's business. So some information might be sensitive or triggering for some women. So we like to do our content warning before we do that. And then we just talk a little bit about the artwork that Nerily Binder created for us. So in the middle, you've got the woman dancing. She just had her screening. She's HPV free. And then the lines going out are going back to community, to other women, to let them know about the service and how they should go and get their screening done, and then pass on the message around. Then you see the little blue bit in the middle, I suppose the hard blue bit. It's just remembering the women that we've lost to cervical cancer.
Thank you. So here at the WA Cervical Cancer Prevention Program, we are the state branch of the National Cervical Screening Program, so the NCSP. We have an aim to reduce cervical cancer incidence and mortality by maximising screening participation. However, we do also now have a few other priorities, which is to do with vaccination and screening, because we have a new mission, and that is to eliminate cervical cancer in Australia by 2035. Hopefully you've all heard about that goal at some point in the last year, but funnily enough, next week on the 17th of November, we will be commemorating the first ever World Cervical Cancer Elimination Day. So that's on the Monday the 17th. And it's a message that we would like everyone to know about and watch this space, yeah. So there are 3 pillars of elimination. The first one being vaccination. We would like 90% of all boys and girls to receive 1 HPV-containing vaccine before the age of 15. And this is ideally given before first sexual contact. So screening, we have a target of 70% of all eligible women to be screened every 5 years, and 95% of women to receive optimal treatment for cancer and pre-cancer. And so we also have a goal to make this a positive, culturally safe and inclusive experience of prevention and care. So screening is really where our program works, but we can always lead you to information on the vaccination and treatment pathways. So just quickly across the world, this is what the incidence of cervical cancer looks like. So some of these countries in the darker blue might not have a formal cervical screening program. Some of these are actually our closest neighbours that suffer a very high burden of cervical cancer. One of them being Fiji, Papua New Guinea, Tuvalu, and Vanuatu. So we always recommend women from these countries who are coming through services to definitely be offered to have a cervical screening test, because it might be the first time. And we do know that over 50% of global cervical cancer deaths occur in the Asia Pacific region. So this is what worldwide, Australia-wide and in Western Australia, it looks like for incidence and mortality. We do know that over 70% of women who do develop cervical cancer have either never screened or do not screen regularly. And we know that the incidence of cervical cancer in Australia has halved since the introduction of the NCSP. So cervical cancer deaths over time, this is what that looks like. You can see that big drop there. So in 1991, the introduction of the National Cervical Screening Program was introduced in Australia. It was 1992 in WA. And in 2007 there, we had the introduction of the HPV vaccination program. And a few of you might remember, I was in year 9. I remember I got all 3 doses, and now it's just 1 dose. Isn't that fantastic? And we're giving it now. Instead of just to girls, we're giving it to boys and girls. So we know that since the introduction of the NCSP in 1991, cervical cancer deaths have halved. It's more than halved. So we do know that our very remote women and our most disadvantaged women carry the highest burden of cervical cancer. So we really do want to have services that meet the needs of communities and these women, and that they're accessing safe services.
We do know that Aboriginal women are 2.5 times more likely to be diagnosed with cervical cancer, and just under 4 times more likely to die from cervical cancer. And as we spoke about, this is normally due to either under-screening or the late detection, that they're not coming in for the regular screening. And then we do have some barriers that throughout the program, throughout the years, we've talked to community members. So some of the barriers are the stigma of HPV being an STI. Some of the women feeling nervous actually about the testing. They don't necessarily want to go in and get it done, or they may have that male GP that they're not feeling comfortable with, which comes to the shame. And then not wanting people to know that you're actually getting the test. If they believe that it's an STI, then they don't want people knowing they're actually going in and having a HPV testing for that stigma reason.
Thank you. So throughout country WA, this is what our statistics looks like for cervical screening participation. So we do have a couple of priority areas. Up in the Pilbara, we do a few visits there over the last, we have done a few visits there over the last few years. They've been great productive visits, because we do know that the screening rates are lowest there. I was also lucky enough to go to the Midwest as well recently, which was a great trip. So just raising awareness that cervical screening is now every 5 years, and who exactly we want to be testing, and yeah, just spreading the message. So this is a picture of us in 2023 in November, which I now know is probably not the best time to go to, because there's lots of people leaving community at that time, but it was such a great trip, and we got to talk to lots of different health professionals about cervical cancer elimination. And that's Kay there holding our flip chart, which I'm sure many people are familiar with. And the flip chart, I'm happy to report, is undergoing a bit of an update at the moment, and Kelly's doing that. So if you've got any ideas, please email Kelly about that. So down in the Perth metro area, this is what screening looks like. We do have an area of interest in the South Metro and Peel region. So that was our region of focus last year. However, we are still continuing that push down in that area. And what we did was we did a social media campaign. And we also did a community feedback survey. So we got some really great results from that community feedback survey. But I would say that the main cause that women weren't getting screened was the barrier of having a very long wait at the GP, a potential cost involved, and also having maybe a male practitioner. So we really do want to get nurses, midwives and Aboriginal health practitioners screening, and that is a project that we're currently working on to take down that barrier. So prevention in Australia is two-pronged. We have primary prevention, being the National HPV Vaccination Program, and we have the secondary prevention, which is the National Cervical Screening Program. So there is a little bit of a delay. So when people are vaccinated, they're ideally being vaccinated before they're age 15. And then we have a 10-year wait before people turn 25 and they're invited to start screening for the first time. But during that 10-year wait, we want to make sure that people are aware that if they have any symptoms, which we'll go through soon, please don't wait till you're 25. Please go and see your GP before then, and you can have an early cervical screening. So vaccine coverage is dropping a little bit. So what we do know is that the latest vaccination stats came out and that they have dropped just a little bit further in the year of 2024. So the target for elimination of cervical cancer is 90% of boys and girls having received an HPV vaccine. Cervical screening participation in WA, overall, we're not doing too badly compared to other states. However, there are some pockets within our state where there is screening as low as 19%, which is very low. Yeah. And also we know that the most common age to be diagnosed with cervical cancer is between 35 and 50 years old, very, very young. So the participation by age, you can see there, those 25 to 29-year-olds are doing very well. And then as we age and we get busier, things change. We kind of just, the screening just goes all the way down to the bottom, where we know that our older women are not screening as often as the young women. So that's a common misconception that we don't need to screen as much later in life, but that's not true. We still do need to screen. So we need to be encouraging our friends, aunties, sisters, nans to keep screening across our lifetime. So a little true or false. Do women who are vaccinated against HPV, do they still require a regular CST? That is true. So what we do know is that there are over 100 types of HPV. 40 of them, over 40 of them, affect the anogenital region. So HPV vaccination, which is called Gardasil 9, because it covers the 9 most harmful types, the oncogenic cancer-causing types, which are written there, and mainly we're looking at that type 16 and type 18 HPV, because we know that they cause over 70% of all cervical cancers. So we also know now HPV is very, very common. 9 in 10 of us are going to meet this virus in our life. So it's really important that we take the STI talk out of it almost, because most of us are going to be exposed at some point. But we do know that most of us will also clear the infection within 1 to 2 years naturally with our immune system. However, there are some types of HPV that may persist, and that's when they can cause issues. I'll show you a slide on that after. But we know it's spread through any sexual contact. So this is the Gardasil 9 on the right, and we do also have a catch-up program for free for anyone up until age 26. And we know that vaccination is not recommended in pregnancy. So just a quick another true or false. Do women who are in a same-sex relationship, do they still need a regular CST? Yes, that is true. Not always was this known, very well known with our health professionals, but it is true because we now know that HPV can be spread skin to skin, mucosa to mucosa, digitally, orally, or penile. And we know that 99% of all cervical cancers are linked to an infection with a high-risk human papillomavirus. So, as I mentioned, most of us will clear that infection in 1 to 2 years. Some people like to refer to HPV as the common cold of sex. Have you heard that before? Yeah, it's a good one. It just goes to show how common it is. And interestingly, HPV is actually, it's the wart on your foot. It might be like a little wart on your finger or your elbow. That's all HPV. So there's many, many different types, and it's just, yeah, when it comes to the cervix, I'll show you a picture of a real cervix soon. There's just an area that if the HPV gets in there, it can cause a few issues. So this infographic shows us how we can become infected with HPV and how we can regress and clear that infection naturally, or sometimes over 10 to 15 years, we now know, it can persist and progress into an invasive cervical cancer. And that just is another reason why the program has gone out to 5 years. So now that we know that it's a very slow growing cancer, we've got 10 to 15 years to catch it, we absolutely recommend all women be going for their 5-yearly testing. And some people might be on a 12-monthly testing pathway. It's just between you and your health professional of what kind of pathway you're on. But we also know that women who may have a lower immune system, they may need 3-yearly testing because they might not be getting rid of that. They might not be regressing and clearing that virus the same way. So compared to what a pap smear looked like, we've got the pap smear. It was a cytology test. It was every 2 years and the age range was different. So now we've changed to a cervical screening test. Some people will still call it pap smear and that's okay. But now we call it CST. It's an HPV-based test and we can reflex and look at the cytology if necessary. It's every 5 years and the age range has changed to start at 25 and end at 74. Although, if you still want to screen past 74, we would absolutely encourage that too. So women now have a choice of how they want to screen. Would you like to talk to this one, Kelly?
Thank you. So when you go into your doctor, we are hoping everyone is giving every woman the choice. So you can have the healthcare provided check, which we say is just the normal one, where you get a sample from the cervix, which contains some of the cervical cells, checks for the HPV, and then if the HPV is found, then that same sample is checked for any abnormal cervical cells changes. Then we have the self-collect, which looks like COVID swab for the vagina. So it's just a sample is collected from the vagina wall. It's only checking for HPV. It doesn't take any of the cervical cells because you're not actually going up into the cervix. If HPV is found, then that woman will need to come back so we can get a sample from her cervical cells so we can check for any changes. So that would probably be the only difference is there. If it's a self-collect and something is found, we need for her to come back for checking.
So about 1 in 10 of us will be invited to come back and have a speculum examination with consent.
Sorry, I forgot what was next.
That's right.
So we're doing your own cell collection. We actually put out to community around reasons what their concerns were, and some women were choosing still to do the GP collection because they were worried that they're not going to do it properly and they're going to miss something if they do a self-collect. And then others will say, well, yeah, I would rather the Aboriginal health worker was with me in the room, so just had that bit more support. And then others, again, would rather the doctor do it to make sure it's done right. Yes. But giving that option is so each woman has their choice. They have that choice to bring in the chaperone as well, just to make sure that they feel more comfortable. But yeah, we've got some data showing that about 46% of women are actually wanting to collect their own sample, which is great because that means some of these women may not have actually screened without that option.
Yes, it's amazing. So this is the cervix, just here. It's actually a muscle. It's at the top of the entrance to the vagina, and it's what holds the baby in when we have a baby. So it's a very good, strong muscle. And I just want to show you a picture of where the columnar epithelial cells and the squamous cells meet. So it's going to be a picture of a real cervix, but it's going to show us why we use the shape brush that we do. So this is a normal cervix with a transformation zone. As you can see, that little ridge around where the light pink and the dark pink meet, that is actually where cervical cancer starts. So it's just an area there where the cells meet called the transformation zone, and that's where we need to sample. So when you see the cytobroom above, that's exactly why it's created in a shape like that, because we want to always make sure that we're sampling the cells of the transformation zone. And the transformation zone changes across our life. So sometimes there might be another brush or a little spatula that the doctor should use, but it should never hurt. You can always say stop as well, definitely take a chaperone as well, but it should just, it's like a tickle. Most of us have probably had one before, and it's just a part of you that, yeah, you're just not quite sure, but it should never hurt. It's a gentle broom. So cervical screening in pregnancy is now recommended at any gestation. So cervical screening can be safely performed at any time during pregnancy, provided that the correct sampling equipment is used. So that broom that I showed you before, as long as they're using that one gently, it can sometimes cause a little bit of contact bleeding, and you need to provide informed consent if someone's pregnant, because that can be very alarming. But self-collection and using the cyto broom is safe. We do know that cervical cancer is the most common gynecological malignancy, so the most commonly diagnosed gynecological cancer during pregnancy. So we want to make sure that every woman has the opportunity to participate in cervical screening, and sometimes pregnancy care is a good opportunity. So it's strongly recommended that routine antenatal care involves a CST when due or overdue. For some women, pregnancy might be the first or only opportunity to have a CST. We also know that women who have experienced early sexual contact or are survivors of abuse can have a one-off test that is offered between the age of 20 and 25. So for these women, they don't have to wait until they're 25, they can have one at 20. And of course, if anyone's symptomatic, we don't recommend you wait even until you're 20, go in and have a test. Immune deficient women, so I'll go through what the categories are for immune deficiency after, but require 3-year testing. And then DES, diethylstilbestrol, that big word down there, that is a type of synthetic estrogen that was given to women between the 1940s and the 1970s that was used to help women to suppress lactation. Not everyone knows whether they've had it or not, so it's really important that if you do find out that you have been exposed to DES or a woman in your care has, they require an annual co-test. So that's a clinician collected sample from the cervix every year. So the tools for sampling in pregnancy, we have self-collect with a swab, that is safe. A gentle cyto broom is safe. But we know that the endocervical brush, the one just down there that looks like a bit of a, looks almost like a pipe cleaner or a eyebrow brush, that one is not recommended for use in pregnancy. So that's very important. So we also do have a new quick reference guide, which is a cervical screening during pregnancy card. It's just an A4 wipeable piece of cardboard that you can use and have in your clinic room. You can order them from us, and it's got the side A and side B, and that is to do with cervical screening during pregnancy. You may have seen our other cards that go in the same suite. We've now got 4 quick reference guides. So this is the path form. We're using lots of different labs across WA, but the most important thing is that you always label the swab. So if this swab isn't labelled and it doesn't go with a form, which is sometimes happening when people take the test home. So we're always encouraging in-clinic testing because we can guarantee that the swab will be labelled and that the pathology form will be filled out correctly. And also the sample collection to lab cannot exceed 28 days. Otherwise it will be rejected. So it's really important as well if we do a self-collected test that we write self-collected and put as many clinical notes as possible. And we always have to have that Medicare provider number and that consenting person with the Medicare provider number to follow up the test. So this is the testing pathway. It was updated this year in April. So the new pathway has a few different updates to it. It's really important to see that tiny grey box in the middle. That one is a deviation to the pathway for women who are Aboriginal and or Torres Strait Islander, women aged over 50, and anyone who's overdue for screening by at least 2 years. That's going to change the pathway that they're on. And they might need to go to have a liquid-based cytology sample, and they may need to go to colposcopy. And colposcopy is just when we ask women to go and see a specialist and their cervix would be looked at under a microscope. It doesn't always mean that they're going to touch your cervix or anything. It just looks like a bit of it's almost like a telescope, but it just shines a very bright light. And sometimes they'll just have a look at the cervix, and sometimes they'll do a small, like almost a vinegar onto the cervix, and it will just show the different cells and what's happening. Yeah, we've actually got a really good brochure on colposcopy if you would like to order that from us as well. But we don't want people to be scared of getting a colposcopy. So in April, we also had some updates to the clinical guidelines to do with follow-up testing. Testing after somebody has had a high-risk cervical screening, and women who have had a hysterectomy. So you can see the summary of those changes there. We can also, this is being recorded, so that's good. We'll be able to get back to that QR code. And the 3-yearly testing for women with immune deficiencies. So they're all listed there. This is women who are on treatment for cancer, dialysis of more than 6 months, any women living with HIV or who have had an organ transplant. If you have any more questions about that one, you can contact us or talk to your doctor. And then there's also a summary there to look at. So signs and symptoms of cervical cancer. We know that any abnormal vaginal bleeding should always be investigated. So this is abnormal bleeding. It can almost be even like a pink watery discharge after sex, between periods and postmenopause. Any abnormal vaginal discharge. So as women, we know ourselves, if something's different, please get it investigated. Deep dyspareunia. So that means deep pelvic pain. So pelvic pain that's you're not quite sure what it is, go and have a CST. It's always good just to rule it out. And it's always important to consider if you're pregnant and you're having abnormal vaginal bleeding and you've been in and everything's okay, but it's persisting, I would go back and say, could you please take a CST? And that's also in the guidelines for the doctors looking after pregnant women. This is about the strategy for the elimination of cervical cancer. It's a really big document, but it is good to read if you have the time. And it just shows that our priority populations include, but are not limited to, the following categories, especially for our women who are Aboriginal and Torres Strait Islander. So we have some really good initiatives happening, really good community-led initiatives happening actually. So let's revisit the elimination targets. We want 90% of boys and girls to be receiving that 1 HPV containing vaccine before they are 15. So mostly in WA, we're giving it between age 12 and 13, but you can actually have it a little bit earlier. And if you haven't had it at school in year 7, I think it's given across the whole state. If you miss out on that school that day, we strongly encourage you to catch up as soon as possible with your GP or AMS. Screening, we want 70% of all women and eligible people with a cervix to be having screening every 5 years. So 5 years is the maximum time between screenings, really, and anything in between, you could go in and have a symptomatic test. And then treatment, 95% of women receiving optimal treatment for cancer and pre-cancer. And this is going to include a treatment pathway for the whole of Australia. So how would you access somebody's cervical screening history? You could access it through your GP software or your AMS software. I think GPs mostly across WA using best practice. I know that we use lots of Communicare and we also use Medical Director. And there's another one there called Gynecology Plus for some specialists. Another way that you can access it is through Proda. So if you don't have a Proda account, you can apply for one via that QR code, but that's a really good way to access it because it will give you the result. And if you don't have Proda, we strongly encourage you to call the 1-800 number just there. So you can call that as a consumer or as a health professional, and they should be answering your call in under 90 seconds. That's their target. So the National Cancer Screening Register holds a single patient record for cervical screening, bowel screening, and lung screening. So the only one missing from that is breast screening, and that is because they are a clinical service, they have their own database. So at 24 years and 9 months, women will be invited to participate in cervical screening for the first time, and they can do it anytime once they're 24 years and 9 months. So say they're going on holiday when they're going to turn 25, you can go the week before, that's okay. You can go up to 3 months before. It used to be very strict that you needed to go on your 25th birthday, but now there's a 3-month forgiveness period. And you will receive an invitation via post and now SMS. Oh, thank goodness they've gone to an SMS, because post just doesn't work,
No.
especially for like, I've moved
Anyone.
4 times in 4 years. Yeah.
Yeah.
And so for technical support, if you want to link your clinical software with the National Cancer Screening Register, that is possible. And I would encourage you to call that 1-800 number and you can book a technical support appointment, ideally before the clinic opens, and they can link your National Cancer Screening Register with your GP software. Do you want to speak to this one?
Yeah.
Sure. Sorry, yeah, we've just...
No, all good. So obviously Kay before me, we've done a lot of consultation, just looking at some enablers for offering for our Aboriginal women to get in and do more screening. So now that we've got the self-collection, we're finding that is one of the best enablers to go. You know, you come in, it's a nice, quick, easy, less invasive test. You can do it in the privacy of the toilet at the GP. Community-led initiatives, I'll probably speak to the people that do it best, but just ensuring that every initiative that we do is looking at the community, what is best practice for the community. Also making sure, obviously, it's culturally appropriate care, which goes hand in hand with that community-led initiatives. One of the things we do find is that flexible service. A bit harder here in the city because it's always booked appointments, but when we're a bit more rural and remote, having a bit more flexible service, if there's a female provider there, can we access them, letting them bring in support people, just making, I suppose, that flexibility a lot more easier for all the women. If you do have a woman with a disability, always book that longer consultation because they might need help with different things like dressing and undressing or the positioning. So just, yeah, obviously making things a lot more flexible for our women is going to help a lot more get those rates up.
Yeah, comfortable. We want people to be, this is something that you're going to be doing across your whole life. So making sure it's comfortable.
And then we have a suite of resources as well for our Aboriginal community. We've got the top left is from, we've taken stuff from the national program and branded it with ours, co-branded it. We have a suite of resources about the prevention, the testing, and what's next, the colposcopy. We also have our flip chart training. So we do an e-online, which I'm just updating at the moment, doing an e-online training that we will be able to get you to do online so you can get all the details on how everything's run. But then we have a hard copy flip chart for those conversations, whether it's in clinic or in a community setting. And then we have other stuff about menopause, hysterectomy, exit testing, lovely bookmarks. But yeah, got a bit of a suite of resources.
And then I just wanted to bring your attention. So there was a national campaign this year, very, very, very successful with the privacy pouch. So I have contacted Nacho to ask if they're going to put any more out because I think they sold out. But if you would like to contact Nacho to get more, I would encourage you to, because I really hope that they do bring out more. It was very, very successful. And then on the right, we've got the national campaign called Own It. And that was a social media campaign and a print campaign that came out to encourage women to talk to their doctor, their nurse, their midwife, their Aboriginal health practitioner about the choices that they now have in screening. So how many women have we met that said, I had a terrible cervical screening and I'm never going back, it was awful. So we want people to know that they have an option to do it themselves, and we can really encourage women to do that who would otherwise not return. So this was just a little slide. We would really love to hear from you of how we can best support your community.
Yeah, so I'm new to the role, so I may have spoken to a few of you already, but I've been trying to just contact everyone from all parts of WA to figure out how can we, as a program, support our Aboriginal community, what is needed from either us or what extra information that's needed to help your community come in and screen more. So I don't know if we have time today to do chats online, but if you contact Noe and myself about what things might be needed in your community or your region, that is just going to help get more women into screen. I'd love to hear from you.
Yes, and we can come, we can
We can do
do visits, we can do events, we can do one-on-one online training or in person. Whatever you need, please, yeah. I strongly recommend you to contact Kelly or myself. And yeah, thank you very, very much for joining us today. This is our contact email that you can contact us on.
Beautiful. I'll pop that in the chat as well. Sorry to cut you off there. We will just open it up if anyone does have any questions at all. Thank you so much, ladies. That was amazing. I definitely learned something. I can't believe 9 in 10.
Yes,
Wow.
I know. So we really need to remove that stigma, don't we? 9 in 10 of us are going to meet it. That's 90%.
And kind of nice also just to have that, the warts and elbows or fingers and just kind of normalise it.
Yeah.
It's, remove that STI like you were saying. So that's a really nice way to sort of frame it as well. But yes, we will open it up if anyone does have any questions. One, I suppose, I don't know if you could answer this. I know we spoke a little bit about vaccination earlier. Sometimes a question that comes up is, because you have got the catch up until 26, and a question that I find does come up is people are like, should you get it if you didn't get it to that before 26? Because you obviously have to have the 3 doses instead, and that can be a bit costly and it's not covered under the guidelines. Do you have any information on that? Or
yes, there is definitely some efficacy after 26. Because we know that there are over 100 types of HPV, you may not have been exposed to some of the strains that are in the Gardasil 9. So the 9 most harmful types that are in that vaccine, you may not have been exposed to them. So there will definitely be some efficacy getting it after. We don't know how much, but it's still some. Do you have anything to add to that?
No,
yeah, I would strongly recommend you to still get it.
Beautiful, thank you. Monique, I believe you should be able to unmute yourself and pop your camera on if you wanted to, but ask away if you've got a question there.
Yeah. So hi, I'm Monica. I work as a registered nurse in PAMS, Newman. I was going through some patients' file and wanted to check their screening history on NCSR, but some patient doesn't have their Medicare number, so there's no data. So just wanted to ask if I can just call that number you have given, 1800 number, and put give the Medicare number to access the data, or how does it work? How can I feed the Medicare number to NCSR for for the history and stuff?
I would definitely recommend calling them. You need 5 points of ID. So if you have 5 points of ID otherwise, do you have anything to add to that, Veronica?
I know when I rang them, it's been a while since I've rang them. I think, you've got name, date of birth. If you've got a current address, you need the provider number of the person, of the GP you're working with. So I think that is another thing that they want. So who is the provider?
Okay, and then your phone number or?
Yeah, but look, is the 1-800 number available after hours, or is it only during office hours?
That is a good question. I believe it goes until 5 p.m. our time.
Oh, okay, 5 p.m. our time.
Although the people who are answering the phones are in Canberra.
Right. Monique, I think it's definitely worth a try to phone the register.
Yes.
Yeah, and see if you can sort of access that patient's record. You can always give them a Medicare number that might be out of date, perhaps, because that often what changes with the Medicare number is just like the last digit or so. So I think, I would be surprised if you weren't able to access it.
Yes.
Yeah.
And then if
Okay.
you ever have a lot of trouble beyond that, please email our program because we might be also able to help you.
Okay, cool.
Even with
Thanks.
this case, if you don't, have any success, please email me.
Cool. Will do. Thank you.
Thank you.
I think that's a very good question though that Monique's
Yes.
brought up, because a lot of our patients, we do have issues with Medicare,
Okay.
because Medicare cards will get sent to an address, but we have a large transient population. So sometimes we order the Medicare cards to come to the AMS. So it is a real issue with Medicare cards.
Okay.
Mm.
That's a good idea to get around that.
Wonderful, thank you. Any other questions before we wrap it up? If you come up with anything or have anything burning that might pop into your head, please reach out via email. I can definitely pass it on to,
Yes, that would be great.
to Noni and Kelly. Also happy to link anyone in as needed, but we will might just wrap it up there, I think.
Yeah.
And
I was just going to mention quickly, if anybody would like to have an event on next Monday, I know it's short notice, but it is that World Cervical Cancer Elimination Day. It's the first one ever. We do have some beautiful bunting that we could express post to you. It may make it. Yeah.
great, yeah. If anyone wants any, let us know. We can pass it on straight away and get that up wherever you may be. But otherwise, we might call it there for now. Thank you all so much for joining us. We'll send this out. And thanks again to Kelly and Noni.
Yeah, thanks, guys.
All right, thanks everyone.
Thank
See
you.
you.